On Dr. Balachandar S. for the pro session of this Videolaryngoscope. He's been presenting in national and regional conferences. In 2014, he has given an oral presentation, and in 2014, he has participated in postgraduate quiz at SZISACON. And 2022, he has participated as training faculty in the pre-conference workshop on advanced airway management. And in 2022, he has participated as faculty in the scientific program, presenting a topic on pro and con on open intensive care and closed intensive care. His areas of interest are regional anesthesia, airway, resuscitation. He has got more than 10 publications in his account. We welcome you, sir.
Respected chairpersons, senior professors, and dear friends, good evening to all. Thank you, ma'am. Thank you for your kind introduction, and a special thanks to the those who are present here. See, I'm here to speak in favor of the fact that videolaryngoscopy should be the standard of care for tracheal intubation. And before that, I must confess that I'm not here to say that direct laryngoscopy is obsolete, or VLscopy, that is videolaryngoscopy, should replace direct laryngoscopy, or I'm not here to compare various videolaryngoscopes and identify the best one. So how many of us here would like to use a keypad-based Nokia phone over the present iPhone models? And how many of us would prefer to drive a manual old ambassador car over the present generations where we have a high-tech infotainment systems and safety features? So similarly, everybody here, I'm sure, that would agree that our airway management practice has undergone a significant or a dramatic change with the advent of videolaryngoscope in the last 20 years. And before going to the topic per se, I would like all of us to understand what the differences, the essential differences between indirect and direct laryngoscopy, and what we understand by standard of care. See, as you can see, this Macintosh laryngoscopy is in practice since 1943, since its introduction. And here, it's a method of laryngoscopy where glottic visualization is made by direct line of sight. And by displacing the soft tissue using a force of about 35 to 50 newtons. And it's a technically complicated skill with variable learning curve. Whereas videolaryngoscopy, on the other hand, was made clinically available with major advancements since 2001, and here the glottic visualization is made by indirect way, that is through the camera, which is placed near or the distal end of the laryngoscope blade. So as you can see, it is very clear that our line of sight has shifted from the most proximal end of the laryngoscope blade to the distal end, making the glottic visualization better with a lesser force of about 5 to 14 newtons to expose the laryngeal inlet. And it has a faster learning curve. Now, another thing I would like all of you to remember is the types of the classification system. So for the purpose of this class, let us remember these two types, that is based on type of blade and based on the presence or absence of the guide channel. Now, coming to what we understand by standard of care. It's a benchmark defined as the reasonable level of care expected of the average medical practitioner to a person. And as per EDI's clinical practice policies, there are three types of policies: standards, guidelines, and options. And standards are the one which has to be rigidly followed and in all cases. And guidelines are more flexible and can be followed in most of the cases. There is another dimension to this definition which carries legal implications. So any breach of the standards or not following the standard of care, we are accused of negligence and carries legal liability. However, if there is breach in the guidelines, it can be justified with the differences in the individual clinical circumstances. Now, in the legal sense, if you ask me whether videolaryngoscopy should be a standard of care, I will say no, definitely no. However, what happens is the clinical care is a continuum of care, where at one end we have a barely acceptable care and the other end we have an ultimate care. So in legal terms, the standard of care can lie closer to the barely acceptable care. So in that sense, I would say that it is not an optimal care, and as physicians, we must aim for the optimal care in terms of improved patient safety and better clinical outcomes. Okay. Before seeing the evidences for this, for videolaryngoscopy having improved patient safety and clinical outcomes, I would like to enumerate these factors, how videolaryngoscopy has changed our scope of practice. As you can see, it has provided superior glottic view by obviating the alignment of 3 axes with less lifting force and cervical spine manipulation, and increased first pass intubation success rate in variety of clinical scenarios, and there is improved margin of safety with the visual confirmation of the tracheal tube placement, and there is reduced infection risk, especially during the COVID times we have encountered, and easier skill acquisition when compared to DL scopes. Now coming to evidences, what is its role in the predicted difficult intubation? See, remember, it is predicted difficult intubation, and this is a study where 300 RCT with 300 patients with at least one of the 4 predictors of difficult intubations. They are enumerated there, and as you can see, the proportion of success rate is more with CMAC group when compared to the DL-scopy group, and this difference represents a 52% reduction in the failure rate to intubate the trachea on the first attempt. Now this study shows how videolaryngoscope have effect on the, effectively rescued the failed direct laryngoscopy attempts. As you can see, is one technique has higher success rate of about 92% when compared to the other techniques I have enumerated there. And coming to its role in unanticipated difficult intubation, so these are the studies which provided evidence, robust evidence saying that the VL-scopy has successfully rescued failed DL-scopy in more than 90% of the cases with higher success rate. And this evidence also means that it has been achieved in with the different VL-scopies in different population, diverse population. The point I would like to underscore here is that the benefit of having the videolaryngoscope at every site of airway management or whenever there is a problem of unanticipated difficult airway. Now, let us move on to the higher level of evidence, that is a systematic review and meta-analysis. And this one, Cochrane review was published in 2017, including 64 RCTs. So, focus on the outcome measures. All the outcome measures have said or favored videolaryngoscopy in terms of fewer failure rates, fewer intubation rates, a good degree of CL grading, and reduced complications. You can see the odds ratio favoring the videolaryngoscopy. And this Cochrane review is an updated one of the previous one, which included study after 2017 and also did a subgroup analysis based on the classification of the videolaryngoscope. And as you can see that among the critical outcomes, there is moderate certainty of evidence for higher first attempt success rate and reduced failed intubation. Though the other parameters are showing a low certainty of evidence, the sensitivity analysis have found that every outcome parameters have favored VL scopes over the direct laryngoscopes. And in the same meta-analysis, the other important outcomes were also assessed, and leave out the certainty of evidence, the sensitivity analysis have shown that the VL scopes are better than direct laryngoscopes. Now, as I said earlier, there is, the VL scope should be present at every site. So in this context, there is a concept called universal videolaryngoscope. But it cannot be made available at every site in our Indian setup, and it is still a challenging process. However, there is another aspect to this universal videolaryngoscopy, which is using the videolaryngoscopy as the first attempt of choice in any airway management or tracheal intubation. And this is one such study where De Jong et al. And his colleagues have evaluated this adoption in their before and after observational study. What they did is they utilized or they made the CMAC videolaryngoscope as the first option of choice in their hospitals following educational intervention, and they followed it up for 3 years. So what they have found is during the 3 years, after the end of the 3 years, the percentage or the proportion of persons using videolaryngoscope as first choice has improved from 0.27% to 66%. And the easy airways also improved. And as you can see, the use of airway rescue techniques and operator reported difficulties have decreased 3-fold times when compared to the control hospital there. Now, this is another study which has evaluated the feasibility of adopting universal videolaryngoscopy into the practice. However, they have used a structured approach. So they used a 6-step structured approach where they initially did a pre-survey trial. That is, they got the opinions from the anesthesiology consultants and trainees regarding the proposal, and they did logistics plannings and capacity planning, and they implemented a feasibility trial for over 2 months using CMAC as the videolaryngoscope of choice, replacing the conventional laryngoscopy. And the pre-trial survey response, as you can see, more than 50% of them have responded, and they have said that it is beneficial to change to CMAC in terms of patient safety, team dynamics, quality of care, and quality of training. However, there is an interesting finding in this that 40% of them had said that the quality of training would deteriorate when we introduce CMAC. Now let us see after the implementation of the feasibility trial. What happened is, during the trial, they have again did a survey, and they found the level of support. As you can see, among the consultants, 42% were saying absolutely favoring the video laryngoscope pre-trial, and it has improved to 92% after 6 months after the trial. And it is same with the junior trainees, which was assessed in the post-trial period, improving to 45.5%. Now coming to the survey results on the impact of practice, as you can see, the consultant, they had a positive opinion or beneficial opinion on CMAC introduction with 56%. That has improved to 70%. I would like to focus on the junior trainees. See, the improvement is about to 82%. There is another interesting finding is, 8 months after the trial, they again surveyed those trainees who were involved in this study, and they found 84% of them were recommending the CMAC in the regular practice. So from the evidences, it is very clear that the pathway to universal video laryngoscopy is feasible one. The point which we have to remember is, we have to utilize it for all non-urgent intubations. Do not only or restrict its use only for the difficult intubation. Because however, if you do that, we will develop, we will require more time to obtain expertise, and we will have more morbidities and mortalities, especially in unanticipated difficult airway scenarios. Now, what are the guidelines size, our international and national guidelines? See, the recent American guidelines has stressed upon these factors for effective or intubation success. And I am sure that video laryngoscopes will attain this, like improved laryngeal views, higher frequency, and fewer intubation maneuvers. But what we require is expertise and experience, and that we can attain with regular training and implementing the video laryngoscope as the first choice of the equipment. The another point that the American guideline has stressed upon is limiting the number of intubation attempts at tracheal intubation. And I'm sure if we use video laryngoscopy as the first choice, then definitely we are going to restrict or limit the number of attempts. And another point I would like to focus here is, as anesthesiologists, at times of difficult intubation, what we normally do is, we will not focus on intubation rather than mask ventilating and maintaining the oxygenation part, because that is that is essential here. So when we attempt to increase the number of attempts, what we do is we compromise the airway, and our mask ventilation ability also comes down. So that also can be prevented if you implement video laryngoscope as the first option of choice. Now, coming to Canadian focus airway focus group, they have also recommended use of video laryngoscopy, and they have recommended hyperangulated blade in case of cannot ventilate and cannot oxygenate situations. And guidelines from Difficult Airway Society as well recommended the availability and skill in the use of video laryngoscope. And they have also recommended its use in the patients with COVID-19 management, and that is, we all know that. And it is again supported by our All India Difficult Airway Association consensus, also recommended the same thing. So during the pandemic, DLs are no longer acceptable. So what are the factors hindering the pathway to the universal laryngoscopy? The first assumption is, we all think that skill degradation will be there. And many of us will have this, are reluctant to give up the direct laryngoscope. Why? Because the fear of not having the video laryngoscopy in their setup, and in terms of inexperienced operators, right? So what I suggest is, use Macintosh type video laryngoscope and use it for both direct and indirect visualization. So in that case, you can maintain the skills of the direct laryngoscopy with using the Macintosh type video laryngoscopy. Is there any evidence? Yes, this study is one of the evidence, where what they did is, the proportion of Cormack-Lehane grade 3 and 4 were assessed using direct laryngoscopy with Macintosh laryngoscope, and with that of direct laryngoscopy with non-angulated video laryngoscopy, CMAC and McGrath were used. And they found comparable results, and they found equivocal. Another advantage is we can rapidly switch from direct line of sight to indirect line of sight whenever we face difficulties with, if we have a higher grade of CL. And in any case, we can call upon senior anesthesiologists who can involve in teaching and training and assist the junior trainees also, so that their learning curves also will be improved. The second factor which I would like to focus here is the cost barrier. And most of us here, I think, would agree or would have seen how ultrasound has progressed in our clinical practice, how it has, become the part of our practice in, especially with neuraxial blockade or peripheral nerve blockade or vascular access. So similarly, cost will not be the problem in case of a videolaryngoscope as well, and it will happen that it will be present in every place or in every OTs. Now, coming to the question whether videolaryngoscopy should be the standard of care for tracheal intubation, my answer is yes, because it has become the core component of modern airway management, showing better clinical outcomes and improved patient safety. And what we have to focus is, as any skill required training and practice, we must develop it by using it as universal availability and training as part of the program. And we know that no single airway device has given 100% success rate. And I believe that videolaryngoscopy is the bridge between the conventional laryngoscopy at one end and the advanced airway techniques like fiber optic bronchoscopy at the other end. And I am sure that it has overlapping roles at both the ends. And cost factor, I must say patient safety is of paramount importance than the cost factor. And we have increasing recommendations from the national and international guidelines for the availability and skill acquisition and first line use of videolaryngoscopes. And the last statement, that stress levels of anesthetists, though I don't have any evidence, but I must say that I think most of us would agree, with the presence of videolaryngoscope, we feel secure and confident in managing an airway case. Thank you. With this, I rest my case. I thank the organizers for giving me this opportunity and for your patience listening.